A 5-year-old male newborn is brought to the physician by his parents for evaluation of irritability and poor feeding that began 2 days back. He was delivered at 40 weeks gestation. Birth weight is 3.2 kg. His 8-year-old sister and his father are healthy. Both pregnancy, his mother had severe polyuria. Today he weighs 2.9 kg. Physical examination shows dry skin, mucous membrane, and decreased skin turgor, and shrunken anterior frontal, which are the signs of dehydration. During the examination, he cries without tears. Laboratory study shows a serum osmolality of 305 and urine osmolality of 45. After the administration of vasopressin, that is ADH analog, urine osmolality remains decreased. Okay, which of the following is most appropriate treatment for newborn's condition? After administration of vasopressin analog, so what does vasopressin do? What is the activity of vasopressin? ADH, right? What does ADH do? ADH helps in retention of free water retention. Not sodium and water retention, only free water retention is the action of ADH, mainly water. Okay, remains okay. After the administration of vasopressin, urine osmolality remains decreased. Correct. Which of the following is most likely appropriate treatment for newborn's condition? So the basically the newborn is having a condition where there is mutation in the vasopressin receptor. Okay, they say this is X-linked. Okay, nephrogenic diabetes insipidus. Sorry, diabetes insipidus. That is X-linked is what they're telling. So X-linked mutation is always important in males, right? There is only one X allele, XY gene allele. There is only X1X. So XX females are normally asymptomatic, or they might have less severe diabetes insipidus. Okay, so the male baby is symptomatic now if he is having all the signs of dehydration because he's having polyuria, correct? Also, he is irritable and poor feeding because of dehydration. Now, let's read the answers. Why is it in indomethacin? Tell me, what is indomethacin? What is it? I've already told about NSAIDs, but tell me what is indomethacin? It is an NSAID, correct? And the concept I've told already, it inhibits prostaglandin. So what happens is there is decreased GFR, right? There is decreased GFR. The body thinks there is decreased renal blood flow. So there is increased ADH activity. Correct? Increase in free water retention. Let's read. Indomethacin decreases diuresis. Okay, let's read about it. Indomethacin decreases diuresis. How? In the patients with nephrogenic diabetes insipidus by inhibiting the synthesis of renal prostaglandin, which physiologically inhibits the action of ADH on the conducting ducts. This male newborn has hereditary nephrogenic DI, most commonly caused by X-linked mutation in the vasopressin receptor, right? Which results in failure of principal cells to respond to the vasopressin receptor. Females with heterozygous mutation are typically as asymptomatic because of the presence of functional gene, right? However, they may develop polyuria during pregnancy, as seen with this neonate's mother, because of increased clearance of vasopressin. So there is something called placental vasopressinase that causes clearance of vasopressin. So the action of vasopressin is not happening, so there is polyuria. Got it? Now, so what happens is, how does indomethacin decreases diuresis? Did everyone come to know? This is quite confusing, but whatever I told is it makes sense for you, right? Other treatments also, yeah. Other treatments also, that is amuloride. Yes, the other options do you mean the other options? Demiclocycline and stuff? Are you asking for that? There are other options? Yes. Yes. So hydrochlorothiazide and amiodaride, right? Amiodaride is what I would have revised. I should have revised this. Amiodaride is what? Let us decipher together. So okay, diabetes insipidus is what? There is decreased ADH or there is decreased action of ADH on the kidney, correct? So the ADH is normal and the action of ADH on the kidney is decreased. So one is central diabetes insipidus where there is decreased ADH. This is central. And there is decreased action of ADH, which is nephrogenic. So let's say, how do you differentiate this? So if you give external analog of vasopressin, which improves? Central improves or nephrogenic improves? Central improves because our receptors are normal. Only our ADH from the posterior pituitary is not acting. So if you give vasopressin analog, central diabetes mellitus uh, is okay, right? Nephrogenic doesn't improve, correct? Now, what are the treatments of diabetes insipidus is what they're telling. So indomethacin, which causes decreased diuresis. Okay, amiodaride is potassium sparing diuretic. So what do you have to do in diabetes insipidus? Either you have to give vasopressin analog in central, or you have to cause. I'm not sure. Like, do they have an explanation how amiloride and hydrochlorothiazide causes treatment of diabetic insipidus? I just know this important point where lithium causes decreased action of aquaporin 2. So lithium causes. They don't know. Okay, they have not told. Even I want to find out now. It's kind of killing me. Okay, so basically they're telling it is a potassium sparing. We can proceed. Yeah, cool. I'll explain in the next class. But lithium causes nephrogenic diabetes mellitus. Sorry, nephrogenic diabetic insipidus because it causes there is some mutation in aquaporin 2 that is caused by lithium. So lithium acts similar to sodium. Okay, so instead of sodium, the lithium is taken. Okay, lithium is taken in by the aquaporin 2, and there is decreased. Lithium is taken by the sodium channel inside the collecting duct, and there is a decreased formation of aquaporin 2. So if your aquaporin 2 is not formed, there is no pre-water retention. So that's why it causes nephrogenic diabetes insipidus. So amiloride causes decreased activity. So amiloride prevents uh, taking up of lithium now. That's what they say. Amiloride acts like that. Let's proceed. Okay, indomethacin. This we read. Okay, high protein diet is contraindicated in patients with diabetes insipidus because it increases renal urea excretion. So increase protein, increase muscle mass, increase urea excretion. Okay, which also increased protein causes what? It increases osmolality and increases solute diuresis. So if you're eating more, there is the concentration of the urine increases, and obviously increase in solute diuresis, and it worsens polyuria. So you don't want to give your patient high protein diet. Excessive sodium intake is also contraindicated in patient with diabetes insipidus because it causes natriuresis. Okay, it worsens polyuria. So whatever excess you give, if it's causing polyuria, you don't want to give that. So what is demeclocycline? I asked you that time. It is ADH antagonist. Okay, that induces nephrogenic diabetes insipidus. Why do you want to give a drug which is already worsening, which the Yeah, you got confused. It's fine. ADH is not there basically, or it is not acting properly. You don't want to give an antagonist, right? Now, desmopressin is an analog, correct, but it is given in central diabetes insipidus, not nephrogenic.
Thanks for watching. Please give a thumbs up and subscribe for more.